let's talk about chest wall and ventilatory disorders. So this is your chest wall. We talked about this earlier in physiology, but again, I'm just going to go through it very quickly. So, you know all about this in anatomy, and earlier on we talked about this, right? The only thing I want to remind you again is that the outward recoil of the chest wall and the inward recoil of the lungs at functional residual capacity keeps the intrapleural pressure negative at about -5. Remember I told you that when the lungs are in equilibrium, the chest wall is about 90% of its maximum volume, right? But the lungs are actually about 10%. There's that discrepancy. So the lungs are constantly in the state of wanting to expand. The chest wall constantly in the state of wanting to expand. All right? And that is why you get all those acute pressure changes when somebody gets stabbed in the chest and you connect the chest wall to the outside. The pressure changes very quickly and all those stuff happens. The only thing I need you to remember here is what is in the box there. The intrapleural pressure is negative because of the relative difference in the maximum volume of the thoracic cavity and the lungs when no air is blowing. That's your functional residual capacity. Okay? So again, you see that, and the reason that is possible, and I remember when I told you about this earlier, I told you the thorax function like a bag valve device. You know what that thing that makes loose? Right, okay. So the reason the chest wall could do that is because it has a bony component and a cartilage component. So that gives it a springing quality, right? It gives it a springing quality. And that's why if you punch somebody in the chest, you can see the chest will push back because it's elastic, right? And that's why you can do chest compression, right? The reason you can do chest compression is because the chest wall is elastic. If the chest wall is elastic, you can't do chest compression, right? Okay. So extremely important that you remember that because it has a lot of implication for clinical medicine. And I'm sure you talked about this in anatomy, but I want to remind you again that when we talk about the body, we divide the body into planes. We talk about frontal plane, sagittal plane, and transverse plane. And the frontal plane is also known as the coronal plane, right? It divides the body into anterior and posterior section, okay? The sagittal plane is known as the median plane. It divides the body into right and left sections, and the transverse plane, known as the horizontal plane, divides the body into upper and lower. These are very important, especially in the lungs, because we're going to be talking about some things. So now let's talk about, so that's just background. Now let's talk about the disorders themselves. These are very important disorders. You can have chest wall disorders that affect the, where is Bradley? You can have chest wall disorders that affect the thoracic spine, the rib cage, or the intercostal muscles, right? So any of these components of the chest wall can be affected. Now in terms of thoracic spine, you can have kyphosis, right? You can have scoliosis, and you can have kyphoscoliosis when both of them occur together, right? Kyphosis, scoliosis, and it can be combined. For the rib cage, there are two types of abnormalities. You can have congenital deformities. They call them pectus excavatum, pectus carinatum, and pectus arcuatum, right? Pectus carinatum is also known as pigeon chest, right? Because it just looks like a pigeon, right? Like a pigeon's chest, all right? But then it could also be acquired. Of all these chest wall disorders, the most common one is this acquired ribcage disorder known as costochondritis. Because you see, costochondritis is a form of arthritis, and arthritis is very common. And the reason costochondritis gets a lot of attention is because patients come complaining of chest pain, right? So when somebody comes complaining of chest pain, as a clinician, your antenna will go up, because what are you going to think about? Cardiac problem, right? So if you are not able to exclude costochondritis, you will do a hell of a lot more EKG than anybody else. You will do a lot more referrals to cardiology than anybody else. When all you really need to do is put pressure on the chest. Because in costochondritis, when you put pressure on the chest, the patient feels pain. The chest, anterior chest wall is tender. Heart attack does not give you chest wall tenderness. It does not matter, even if the patient is having a global myocardial infarction, the patient will never feel pain because you compress the chest. So if you compress the chest and the patient says, oh, that hurts, that's exactly the pain I'm talking about, just send them home with aspirin or ibuprofen. You don't need EKG or anything, right? So that is why this is so important, costochondritis, okay? And of course, you have intercostal muscles that can be affected either because the nerve supply is affected or because the muscle itself is diseased or they have disease of the neuromuscular junction. Can somebody give me 2 examples of diseases of the neuromuscular junction? Myasthenia gravis and Lambert Eaton. Good. Excellent. All right. Okay. So, then you have skin and soft tissue disorders like Pickwickian syndrome. You remember that? And what is Pickwickian syndrome? It's excessive accumulation of fat in the chest wall that weighs down the thorax, basically causing hypoventilation. You know all that. All right, so let's see how do we clinically evaluate these things. So scoliosis is sideways curvature of the spine, right? So we're going to talk about the classification of it and the presentation of it. Scoliosis is sideways curvature of the spine. You can classify it based on pathology or pathogenesis. You know, I keep getting this feedback. You're not the first group. Everybody keeps telling me, can he put more words on his slides? I don't know, put more words. Like, put more words on the slide. I'm like, I read other people's comments and the slides are too wordy. Put more slides. Like, do you just want me to put words? So you want to put on the slide the important information? You know, if you don't appreciate my slides, wait until you're reviewing for your exam. You will appreciate it then. Everybody does, believe me. Okay. So I don't know, but if there is something I should have put there, just text it to me. I like to listen to you, believe me. Because you can only make me better. Good. So the classification is based on pathology and pathogenesis. So based on the pathology, you can describe scoliosis as C-shaped or S-shaped. So that sideways curvature can be just a C or it can be an S. You can also describe scoliosis based on its pathogenesis. You know the difference between pathology and pathogenesis, right? Pathology is the disease, pathogenesis is the causation of it. Okay? The abnormal function associated with the pathology is called pathophysiology. You know that? Okay, so based on pathogenesis, you can talk about it as functional, right? So functional means it's temporary, or it could be structural, which means it's permanent, right? In functional, the spine is actually normal, but it's flexible because the curvature is introduced by vertebral spasm. You know that the reason I am standing straight and looking at you is because my paravertebral muscles, in other words, the muscles that are beside my vertebral column on the right and on the left have the same tone in them. If for any reason I lose tone on my right side, my left paravertebral muscle will twist me like this. And if for any reason I lose tone on the left side, the right paravertebral muscle will put me into a curvature. Okay? So when you have curvatures as a result of differences in muscle tone in the paravertebral muscles, you're going to have a flexible normal spine. And sometimes you have leg length difference, like in sickle cell disease, when you have avascular necrosis of the head of femur, right? And then you let that leg becomes shorter than the other leg. Well, the difference in the leg will tilt the patient. The patient's spine is fine, but the leg length difference is putting them into a curvature. So these are situations where you have curvature of the spine that are functional. In other words, it looks like the patient is curved, but the spine is actually straight. And then you have the structural one. These are relatively permanent. These are fixed abnormality of the spine. 75% of the time, you will never know what is causing it. Okay? About 15% of the time, the kid is born with it. And about 10% of the time, it is acquired. Again, acquired as a result of degenerative joint disease and neuromuscular disorders, neuropathies and myopathies. Okay, so this is all about the classification of scoliosis. How does it present? It doesn't really have a lot of symptoms. Most of the time, in mild to moderate cases, scoliosis is asymptomatic. The patient don't feel anything. Okay? When it is severe, it can cause pain. And the pain could be in the front or in the back, depending on the nature of the scoliosis. If it's a C-shaped or an S-shaped, they will have some kind of thing, right? Either in the chest or in the back. And because these curvatures, they stretch nerves, it can also cause neurologic deficits, okay? So for instance, think about, you know, all the spinal nerves, right? They come out of the foramina on the side of the vertebral column. So if you have scoliosis, you can pinch a nerve on the inside of the curve and stretch the nerve that is on the other side of it. So you can create all these nerve injuries. So patients will present with paresthesias and paralysis, depending on the level of the curvature, right? Okay. So you have pressure of the spine, and then you have respiratory difficulty. Think about it. I mean, remember all those handles, all those movements of the thoracic wall, the bucket handle, the elevation of the sternum, and all those things that enhance the increase in intrathoracic volume that allows you to take a deep breath, right? If you have kyphosis, you can't have all those movements. So your patients can actually have respiratory difficulty. Not because the lungs are diseased, but the lungs cannot expand because the chest wall cannot create the space to expand into, right? Then you can also have circulatory difficulty. I mean, think about that. Scoliosis, maybe not. But in kyphosis, can you think about what could happen if somebody has kyphotic lung? So you're going to have the diaphragm and the sternum manubrium basically crushing the heart, right? And depending on the position of the ventricles, you can actually restrict the ventricles from filling. It would look like a tamponade, right? But it's coming from this curvature from the spine. So you can have all these problems. And then you examine the patient for signs, and you would always find a positive Adams forward bend test. What the heck is that? Positive Adams forward bend test. So basically you have the patient bend forward until the shoulder shoulders are the level of the hip. And you can see the asymmetry. Right? This test is so good. It gives you 0.92 sensitivity. So if it is there, it is there. But it's only 0.62 specificity. So that is why, because of that low specificity, somebody came up with this thing called scoliometer. A scoliometer measures the trunk asymmetry in scoliosis, right? So you place it over the spine, and you can see the dial, and it will show you the degree of the scoliosis. That is how we diagnose scoliosis in the clinic. Okay, did you guys do this physical diagnosis yet? Or you saw your scoliometer, right?
No.
No? So, what did you do?
Just observation.
Oh, okay. Maybe we should, these are not expensive. We should probably get. And as far as maybe the reason it is because you don't really need this to diagnose scoliosis. You can see scoliosis, right? But maybe that is not. But how do you really diagnose scoliosis? So with all these scoliometers and Adams forward bend test, the way you diagnose scoliosis is really with x-rays. So you do what is called a full-length radiographic assessment. And what you're looking for is the curb angle. The curb angle is a weird angle, okay? So basically, they look on the spine for the vertebrae that initiates the curvature and the vertebra that ends the curvature. And you drop a straight line through the superior and inferior border of those two vertebrae. And then you now draw a perpendicular line to that particular line from the superior inferior borders of the vertebrae and look at the angle of intersection of those two. So radiologists do this calculation and then they give you the curve angle. Okay? So that is one thing they do. The other thing they do in scoliosis is actually to look at the sagittal balance. You don't feel the weight of your head, do you? You know why you don't? Because if you look at your cervical spine, the atlas, it runs right through the center of your spine. So your spine supports the weight of your head, so you don't feel it, right? That balance that you get because your head is sitting right is supported by your spine is what's called sagittal balance. So you're sagittally balanced because the entire weight of your head rests on your spine, right? And radiologists have a way of computing that balance from the surgical vertical axis, right? So, generally speaking, spinal curvature is more than 10% to the right or left in the frontal plane establishes the diagnosis of scoliosis. So all you need to diagnose scoliosis is a curve angle of more than 10%, 10 degrees. Okay? We're downhill from here on, both in cardiology and pulmonology, no more complicated subjects. So how do we treat scoliosis? If there is pain, you control the pain. And then you send them for physical therapy. There are scoliosis exercises that physical therapists can put their patients through. And there are devices, traction and suspension devices, and corsets and braces that they can actually put them through. And some patients will actually need scoliosis surgery, where you can fuse the spine with, and then they put these bars. They are made of titanium. Okay? So, I don't send my patients for this surgery. You know why? Unless it's going to really save my patient's life, I stay away from orthopedic surgeons. Because you see what happens is, a patient has something in his spine, right? And they go and there's, okay, let's say the patient has osteophyte. And the osteophyte is compressing. You know, an osteophyte is a scar tissue, right? Okay, so say the osteophyte is now compressing a spinal nerve from where it comes out, and maybe the patient is now getting weak. You tell the orthopedic surgeon, can you go in, please, and chip off the osteophyte? Then he goes in and he replaces the entire vertebra with a metal. Or take it out and put titanium plates. Okay. Yeah, the patient will be relieved of the paralysis because you've taken out the chips. But the truth is, the bone is still going to grow. It's going to try to heal. So the bone is going to grow over your metal, and the patient is going to end up with pain. And you know why I don't like them? They never want to go back in. Never. Surgeons don't like going into the same space twice because they create so much mess at the beginning that they cannot figure out the anatomy the second time. So they will sentence my patients to a lifetime of pain with a surgery they got paid thousands of dollars for, and I get all the headache. So you need to be very careful the way you talk to your patient about surgeries on their spine. In fact, not just about spine, about everything. I just had a big fight at California Hospital on Saturday because I sent my 75-year-old female diabetic from Guatemala. She has hyponatremia. I don't know what is causing the serum sodium to drop. She was in the hospital, and when she goes low in sodium, I mean she goes really low. The last time it was 118. She was already drowsy, she was not eating, and she was vomiting. All I need is for her to aspirate and she'll go into pneumonia and she might even not survive it. She went into the hospital. They said, they diagnosed, no, the first time she went, it was in Kaiser Cadillac. The emergency room physician was so stupid that he started putting IV fluid in the patient before he drew blood and urine for test. What I needed them to do was, can you send the blood for serum osmolality and urine osmolality so we have what we need to figure out what is causing the sodium to drop, instead of pumping the patient up with sodium. By the time I got there, it was 6 hours later, they already messed my patient up. I'm like, okay, so you're not going to fix this. Can you just discontinue the IV fluid for 12 hours and let's do the test so we can figure out what is going on? You know what the guy did? He said, yeah, he will do it, yada, yada, yada. I left. He sent my patient home the next day. He said because utilization review nurse would not allow him to keep the patient. The third day, her daughter called me. She said she's not eating, she's vomiting again. And I had to take her to California. When she got to California, her sodium was 122. You know what they did? Cardiac cath. I went there, like, she told me, they said my mom had 2 blocked arteries. Why are they cutting her? Why did they cut her? So I asked to speak with the intern that was on the service. It's like, can you tell me what the reason was for the catheterization? So she came in with nausea and vomiting, and we thought it could be an inferior MI. I said, but did you see the sodium? He said, yeah, we put our normal saline. Then I told her to go and see the cardiologist. They want to do stent. She's 75 years old. She had compression fracture of the spine. She's in pain all the time. Right? She's diabetic. She has gastroparesis. She has urinary retention because the bladder is weak. Why are you patting her? Why are you even talking about stenting her? So I asked them, I said, okay, so these 2 blood vessels that you found out, how long have they been there? Is she coming with chest pain? Is she coming with shortness of breath? You know why they catch her? Just to build the government. This is healthcare. Those that have the means get excess of it. Those that don't have the means get none of it. Cost is going up every day and nobody is getting healthy because providers have become so money conscious and money driven that sometimes I wonder what the fathers of medicine would think if they were to wake up and see the way medicine is practiced today, especially in America. You know, so I mean, I tell you, okay, don't stand like this. Sometimes it's needed, but you have to do what you have to do. But be careful. So let's talk about kyphosis. So kyphosis is outward curvature of the spine, okay? They call it hunchback in Africa. Americans call it round back, okay? What it is kyphosis, right? You know what the commonest cause of this used to be? TB in developing countries. Because when you get TB of the lungs, it spreads very quickly to the spine. And it causes the necrosis of the vertebra, and the vertebral column collapses. Right? So that used to be the commonest cause of it, not anymore, because now TB is really. What are the causes of kyphosis? Spinal arthritis, age-related spinal arthritis is very common. Okay, that is why you notice that, you know, as you grow older, you should do more weightlifting and straightening your spine and curvature, because the natural tendency is for you to start looking down, you know. And in Africa, they say when you age, you begin to look down because that is where you're going to end up. But it's not because, you know, nobody wants to be looking down because they're going to be buried. No, it's because of kyphosis, age-related. So you do more straightening of your spine with exercise, and you can prevent that. Okay. And then the one that comes with normal aging is what is called the Wiggins hump. Okay. Now, compression fracture, you can prevent. Your bones get weaker with age. That's just what it is. You can take calcium and vitamin D and hormones to keep it up, but invariably you lose some with age. Okay? Osteoporosis, osteomalacia is reversible because it's vitamin D deficiency, and if you give them vitamin D, they can actually restore the bone. You have multiple myeloma, you talked about that, right? It's a plasma cell tumor, right? Okay. And then you have tuberculosis, I told you about that. It's called Pubis deformity. And then you have trauma. The most horrible cause of kyphosis is trauma. So if somebody, for instance, you know, like there was a guy that beat a guy to death on 105 at 12 midnight with a baseball bat. God knows what they were doing on the road, on the freeway at that time. Somebody cut somebody up, he got down, and they started chasing themselves. So when they got to 105, the boat came down, maybe to fight, but he thought they were going to do a fist fight. The guy came out with a baseball bat and whacked him to death with a baseball bat, right? Now, supposing that guy didn't die, if the guy had been able to whack him in the back, say between the upper back, lower back, and the upper abdomen in the back, that's a very vulnerable spot of the spine. You can actually cause kyphosis of the spine in that particular area. And that guy will be just paralyzed from his waist down, and he will just not survive. So he was beaten to death rather than having kyphosis. I don't know which one is better. But trauma is a very bad cause of this, because when it's due to trauma, almost always it will take the spine with it. Okay? Then then you have all these congenital causes like cerebral palsy. We talk about that in the summer, when about pediatrics, and muscular dystrophy, the same thing in pediatrics, Duchenne muscular dystrophy. And then you have developmental, like Schwann's disease. Schwann's disease is a developmental kyphosis. You know what the difference is between congenital and developmental? So congenital means you're born with it. Developmental means you were fine, but growth and development brought about the deformity. So Schwann's disease is a developmental kyphosis. You will see it in juvenile. It runs in families, tends to be more common in girls, and it is due to uneven growth of the vertebrae in the sagittal plane of the spine. So the vertebrae, for some odd reason, they grow faster in the back than in the front. See, so this vertebrae here is growing faster in the back than in the front and putting the spine into a curvature, right? Okay. So they end up with vertebrae that have greater posterior height than anterior height. Okay? That's what Schwann's is. How do you manage kyphosis? The same thing, right? Mild to moderate, you don't do anything, just leave it alone. Moderate to severe, that can cause pain. Worse with erect posture and ambulation, of course, you can understand why that is the case, right? The pain of kyphosis is going to be worse with erect posture because it's only, kyphosis will manifest only when you subject your body to gravity, right? So when you're like this, you're tilting the weight of the trunk out of alignment with your legs. Your leg is supposed to support the trunk. So if kyphosis is making your head and your trunk, part of the trunk, putting it out of alignment with your hip, then that weight is going to put a strain on your muscle in the back. And you're going to have pain. Okay? Again, for the reasons I explained to you for kyphosis, you're going to end up with neurological compromise, respiratory difficulties, and circulatory difficulties for the same reason. Overcrowding of that space. Okay? Again, diagnosis. Normal thoracic spine has a slight curvature of about 20 to 45. You've seen that when you did the cadaver dissection, right? See, the thoracic spine is not straight. In fact, the spine is not straight. The cervical spines come forward, thoracic spine comes backwards, the lumbar spines come forward, right? So there is that S shape. The purpose of the curvature, the normal curvature of the spine is actually to strengthen it. Okay? The spine is more stable because of those curvature than if it was straight. You know, just like when we construct freeways, right? We don't make it straight. Even though we can, we don't. We make it like this. Because if you make it straight, people will put it on cruise control and fall asleep and go wrong into somebody. So the spine is stable, more stable because of the slight curvature along it. Right? Again, how do you really diagnose it? You do radiographic assessment of the thoracic spine, and this time you do a modified curve angle. This is curve angle measured in the sagittal plane. Okay? And then you assess sagittal balance. This is bread and butter stuff. Control pain, again, physiotherapy, kyphosis exercises, and then you have device, traction devices and suspension devices, and you have braces, and if push comes to shove, send them for surgery. You see, it says to live long, active, energetic life, few things matter more than good posture. It's good to exercise, but once you're over 40, you need to start paying attention to your posture. You know, posture is so key. Many people exercise, and at the end of the day, they end up with a lot of muscles, and they never took care of their postures. They end up with all these kind of scoliosis and problems. They look strong and everything, but they're like this, right? You want to be like this, or you want to be like this? So pay attention to your posture, okay? So let's talk about kyphoscoliosis. Look at this poor kid. So kyphoscoliosis is really an abnormal curvature of the spine in both coronal and sagittal planes. Clinical manifestations, again, asymptomatic in mild to moderate cases, symptomatic in moderate to severe cases. Again, pain, all right, worse with erect posture because of the kyphotic component. Neurological compromise and respiratory difficulty and circulatory difficulty for reasons that you already know. Uneven shoulder, uneven hip, unequal leg length. Again, you do the radiographic assessment of curve angle or modified curve angle, and you assess the sagittal balance, and then you determine how you're going to treat it. Most of the time, with kyphoscoliosis, you're going to need surgery. But you can at least, as a primary care person, begin with pain control, send them for physical therapy. The physical therapists, they have all kind of devices and braces and exercises they can use to help the patient. But almost always, you're going to need surgery with kyphoscoliosis. Okay? Now, so that's all about vertebral spine. Let's talk about the rim. So you have this pectus excavatum. You know what excavation is? Right? So excavatum is like somebody's one demon came and scooped part of the chest. That's how it's called. Pectus excavatum, right? It's also known as funnel chest and sunken chest. I had a patient one time that his wife enjoys drinking from his pectus excavatum.
What?
So,
Some different people out here, dude.
was something in there, I will be sucking it out with straw. Right? Love is crazy. Yes.
I saw a patient put a mango in his
Yeah. So
It's ridiculous.
it's known as funnel chest and sunken chest. It really does have a genetic predisposition. So you are born with a genetic predisposition. Then if something happens in your lifetime, you can actually precipitate that excavatum. So you could be born with a potential weakness in the anterior chest wall. And then say you were now born premature and you had hyaline membrane disease, that disease that children are born with, and they are born because of prematurity. Maybe they're born at 32 weeks instead of normal 38, 40 weeks. And then they have respiratory difficulty as children. The pectus excavatum can then be precipitated by that respiratory distress. So they are born normal, but they're born with a potential weakness that the environment now precipitated the excavatum. Okay? How does it, you know what is interesting? It tends to be more common in male for some reason, don't know why. It's not X-linked or Y-linked, anything like that, but it's more common in male. It tends to be asymptomatic. If it's symptomatic, we get pain, respiratory distress, and circulatory disorders for reasons that you already know. There are some factors that can actually predispose you to this, like Marfan syndrome. You know about Marfan syndrome, right? Good. Ehlers-Danlos syndrome, Turner syndrome, Nunes, then osteogenesis imperfecta. You know that? Okay. So all of these over here will predispose you to pectus excavatum. All you need is the right environmental insult, and you're going to end up with pectus excavatum. Okay? Now, how do you diagnose it is very clinical. Once you see it, you've seen it. Okay? You can do X-ray if you want, or CT scan to assess the severity of it. Because you know the truth is that once you see it, you see a depression in the anterior chest wall. What you cannot see is what is happening behind it. What is getting compressed, what is getting squashed, right? If somebody has pectus excavatum and is so high that you think it could be compressing their trachea, then you want to do something to figure out what this might cause, right? Now, how do you treat it? It's very easy. if you can figure it out early, there is this suction device. It's called vacuum bell. If you can diagnose it early in children, when the rib is still very soft, you put the suction thing there and you suck it back out over time, okay? So you have these non-surgical options like vacuum bell. There is magnetic mini mover procedure. You know, in magnetic mini mover procedure, what they do is they put a magnet on the chest wall, put another magnet, and then put some little space between the two magnets so that the upper magnet pulls the lower magnet, and since the lower magnet is attached to the chest wall, it pulls it out. So whatever device you can come up with to pull the chest wall, anterior chest wall out will work, okay? And then you can do surgical repair. All right, so that's all about pectus excavatum. Remember, excavatum is the one that has the hole. Just remember excavation, okay? And then carinatum is pigeon chest. So remember the pigeon chest. So it's called pigeon chest because it comes from overgrowth of the coastal cartilage, okay? It comes from overgrowth of the coastal cartilage. Again, like excavatum, it has a genetic predisposition and environmental precipitation. But the things that predispose, that will precipitate pectus carinatum are not the same as pectus excavatum. So vitamin D deficiency will indeed precipitate pectus carinatum. If a kid is born with, say, tetralogy of Fallot, and they have to split the chest open to fix it, well, it might not heal right, okay? And the kid might end up with pectus carinatum. That is surgically induced pectus carinatum, right? Again, how does it present? Asymptomatic in mild to moderate cases, symptomatic in severe cases, mostly respiratory difficulty. Again, he has a male preponderance. Again, all this connective tissue stuff can predispose to it. And if you actually have respiratory difficulty with pectus carinatum, even though diagnosis is clinical, the diagnosis of pectus carinatum is clinical. But if you want to assess the severity of it, you want to see the impact of it on, say, a patient that has respiratory symptoms, then you can just do a flow volume and you will see the restrictive effect of the pectus carinatum on the chest. Okay, so it will be a restrictive disorder, just like the Quicken syndrome and kyphoscoliosis and all the other stuff. Right? You know that all chest wall disorders are going to present as restrictive lung disease on flow volume loop. Remember that. Right. You know what is interesting? Surgeons are interesting people. We do non-surgical procedures, so you can, if somebody is born with pectus carinatum, you teach them to bodybuild. Because if you bodybuild your pectoralis, right, you can bring your pectoralis up to the level of the carinatum and it won't be obvious anymore, right? You can take some fat from the butt and put it in the breast if the woman has very small breast. So make the breast a little bigger so you can mask the carinatum. I laugh when I read about all these crazy surgeries people are doing. Because they're more cosmetic than really therapeutic, and plans don't pay for them. Okay, so breast augmentation, that is why they do it. Make the breast bigger so you can cover the carinatum. Body build, make the pectoralis bigger so you can mask the carinatum. And then if none of those works, you send the patient for surgery. And they just basically just scrape it off and hope that it doesn't come back. You know, it's like keloids, right? You know keloids, right? You cut them off, what happens? They come right back. You're gonna keep cutting them off? Okay, now this is pectus arcuatum. It's also known as type 2 pectus excavatum. The reason it is called type 2 excavatum, it looks like it's a pectus excavatum of the lower anterior chest wall. typical pectus excavatum is an excavatum of the anterior, the entire length of the anterior chest wall. So the reason this is called type 2 pectus excavatum is that it looks like it's an excavatum that is only limited to the lower half of the sternum, okay? Or it's also known as chondromanubral malformation or Currarino-Silverman syndrome because they describe it, or Porter-Pigeon malformation. All these names refer to pectus aquatum. I've never seen one case of it, so it's not very common. Again, causes genetic predisposition, environmental precipitation. Clinical manifestation is a sternal angle deformity, and the deformity is very specific. The upper part is curved out, and the lower part is curved in, right? So it almost looks like an S-shaped deformity of the sternum, okay? So, because it mimics pectus carinatum of the upper part and excavatum of the lower part, they call it pectus aquatum. Big name for nothing. How do you fix it? The surgery. There is no brace or anything like that for this one. Okay, so this is costochondritis. You're all with me, right? This is bread and butter stuff, right? Good, you just have to know what it is. All right, so costochondritis is inflammation of one or more of the costal cartilages that connect the ribs to the sternum. And the inflammation is specifically at the costochondral junction. Okay? So the inflammation is specifically here. Okay? So the patient, costochondritis is also known as costosternal syndrome or chest wall pain. We don't know what causes it, but just like arthritis, we don't know what causes it. Degeneration, inflammation. Risk factors. If somebody has had a direct trauma or done heavy lifting, like those, if you lift weight a lot, you are putting yourself at risk to some extent, okay? And then chest binding, you know these transgender people, they have breast, but they don't want to appear like they have breast. So they will put this serious banding on the chest to compress and squash the chest before they dress up. It's called banding. When you do enough of that for long enough time, you are putting yourself at risk for costochondritis, okay? Of course, rheumatoid arthritis, and then relapsing polychondritis. You guys talk about that in rheumatology, right?
Not yet. We're still waiting.
But you're okay, it's coming up fully. And then you have infections and neoplasms. So all of these are causes of costochondritis, right? How do you manage it? Another feature of costochondritis is that the pain is actually pleuritic. Okay, so it comes on with a deep breath. Okay, and it comes with chest wall tenderness. That is the unique thing. Okay, so somebody will come with chest pain, anterior chest wall tenderness, lungs are clear, and the chest pain is pleuritic. The reason it's pleuritic is because it is the rib cage that is inflamed and it moves in inspiration, so they will have pain in inspiration. Okay? Don't ever forget costochondral tenderness. Very important. That is why if you're going to send anybody home with chest pain that has costochondritis, you make sure you diagnose, you document positive chest compression test or anterior wall tenderness, so people know that you know what you're doing. You talk to them. If you just say chest pain with positive anterior chest wall tenderness, everybody knows you think this is costochondritis. Okay. syndrome, or type 6. More commonly, it's called type 6 syndrome. It's a costochondritis with costochondral swelling. So if you look, and there is costochondral swelling, that is a type 6 syndrome, not just costochondritis. Okay? It's basically a more severe form of the inflammation. Okay? It's not a separate disease as such. Well, you know, in medicine, people compete for opportunities to name stuff after themselves, right? Because the original costochondritis did not have that swelling. The guy that found the swelling said, we got to call this type 6 syndrome. So we call it type 6 syndrome. Okay? How do you treat it? Mostly NSAIDs. I've never had to use steroids for costochondritis before. You might be the first unfortunate person to have to use steroids. Because you don't have to use steroids, NSAIDs don't work. And the prednisone is what we use, usually with 5 milligrams QD, and hope that it works. Alright? So this is what the swelling looks like. And now, because of the location of costochondritis to the anterior chest wall, you really have to think about a number of things when you see it. And these are some of the differential diagnoses for costochondritis. Do you know what precordial catch syndrome is? Anybody knows what precordial catch syndrome is? I'm sure you've experienced it before. Tell me, let me describe it. Tell me if you've experienced it before. Have there been any day in your life that you try to take a deep breath and it looks like you can't go past like the first tenth of your breath because of this sharp pain that just stops you? And you do it like 3 times, it will stop you, then you wait for like 10 seconds and it goes away, and then you can take a deep breath. But it's like, it stops you like for 2-3 breaths, and then it goes away. We don't know what the heck that is about, but it's called precordial catch syndrome. Okay? So, the way you'll be able to know this is a precordial catch syndrome is take the history. Is the pain there all the time, or does it come and go? You say, no, the pain comes and goes. When does it come? When I try to take a deep breath. It stops me from breathing. Right? And some of your patients will describe that as shortness of breath. That's a curveball right there. Because you have to now step back and say, tell me more about this shortness of breath. There are 2 symptoms that you must always ask patients. Tell me more about this. What do you mean by this? If anybody comes to you and say they're dizzy, and anybody comes to you and say they're short of breath, you must ask them what they mean by that. You know, because dizziness is a very complex clinical symptom. It could come from the cerebellum, it could come from the air, it could come from the heart. And patients feel sick and fatigued, they say they feel dizzy. And they don't want to go to work, they say they feel dizzy. Right? And then dizziness can also come from anemia. So, but it takes different forms, right? So you have to ask the patient every single time somebody tells you they're dizzy or they're short of breath, what do you mean by shortness of breath? And then sleeping rib syndrome, that is a very weak, you know, the cartilage part of the rib and the bony part, they have a joint. It's supposed to be a solid joint. But sometimes that joint is weak in such a way that the bony part rides above the cartilage part. So it's called sleeping rib syndrome. Because the bony part of the rib sleeps above or under the cartilaginous part and causes serious pain. Okay? And then you have intercostal neuralgia, fibromyalgia, herpes zoster. And then it could come from the lungs. You really have to be sure, okay? Pulmonary embolism, spontaneous pneumothorax. All of this you'll find out from your physical examination. And if it's coming from the heart, your patient will have the risk factors, right? EKG and all those things. You have to now do all this workup to make sure you're not dealing with something like that. Do you see why we are so we dread costochondritis? Because underneath a patient with costochondritis could be any one of these. And these are deadly sins. Right. So it could be a red herring. That's why you cannot. The key thing is anterior chest wall is tender, but remember that just because somebody has costochondritis does not mean they cannot have anything else. So if somebody comes to you, say they are 68-year-old, hypertensive, diabetic for 25 years, they've had cabbage, and now they have this anterior chest wall pain, and they have tenderness in the anterior wall, you're not going to say, go home and take aspirin. No, you say, I think this is costochondritis, but can I just do an EKG? You see what I mean? Because you're loaded with risk factors. I'm not just going to say, go home, mistake. No. But if I see a 28-year-old bodybuilding guy comes in with chest pain, non-smoker, non-drinker, no hypertension, no diabetes, I'm like, on the phone, take aspirin and go to sleep. Call me in the morning, right? So you have to kind of be careful with diagnosis of costochondritis, right? All right. So let's talk about respiratory muscle weakness. So we've talked about vertebral problems, kyphosis, scoliosis, kyphoscoliosis. You heard about curve angle for scoliosis. You talked about modified curve angle for kyphosis. We talked about the rib cage problem, excavatum, carinatum, acquaintum, right? All of those, remember that, right? And then we've just talked about the rib cage costochondritis and all of the differential diagnoses. I told you about Tick's syndrome when costochondritis is associated with swelling that is palpable and tender, right? And you always give aspirin and all symptomatic treatment, right? You got all that?
Yes.
Excellent. Now let's talk about respiratory muscle weakness. So it could be a myopathy, a muscular dystrophy, or a neuropathy. Don't worry about Lou Gehrig disease, we talk about it in the summer. This is amyotrophic lateral sclerosis. It could be an ascending paralysis, as in Guillain-Barré syndrome. It could be tick paralysis, descending paralysis, neuromuscular disorders. I know you know neuromuscular disorder, but you don't know about all this paralysis, right? Or did you know about it? You should have talked about tick paralysis in ID, right? Excellent. So tick paralysis is from neurotoxin in tick, right? It's an ascending paralysis. So it's not going to be keep going. You worry about this ascending paralysis because you know what? It starts in the legs, right? And it keeps going. And you have to monitor the patient's minute ventilatory volume. What are you looking for? You want to know when it's beginning to compromise their ability to breathe. Because then they need to be in an intensive care unit where they can be intubated and put on a vent. If you're doing something in a rural area and you suspect somebody's having tick paralysis, and you watch them over 2-3 hours and you look at the rate at which it is ascending, you need to get them out of that rural area to a place, a tertiary center where they can be put on a vent. Because if you delay, very quickly the diaphragm and the intercostals are going to get involved and they will just die. Okay. So you have all these problems. Basically, they are myopathies and neuropathies that affect the respiratory muscles. And I think I just told you about this. The ventilatory capacity of the patient is monitored and supported when forced vital capacity falls below 15 mils per kg, or the negative inspiratory force falls below 60. So forced vital capacity, you already know, right? Negative inspiratory force is when you put they put something that looks like a pig flow in the patient's mouth and tell the patient take a deep breath. And because the patient takes a deep breath, it creates a negative pressure, and the dial swings and tells you how much negative pressure the patient generated, right? RT use it. Okay, and this is about biosonographies and lambert uterine. And I already told you about this, one of the differences between lambert uterine and biosonographies, facial muscles and all that. Remember all that? Okay, don't forget. I'm going to help you remember everything we talked about in this spring, because all the questions we're going to go through on Wednesdays in the summer are going to be based on everything, not just my classes, everything you've learned in the spring, so you will be able to retain it. So when you're reviewing, when you come back from the clinic rotations, you will be really fine, physician, and ready to go. Okay? Big weekend syndrome. This is the story of Big Weekend. Right? It used to be a character developed by Charles Dickens. So it was not a real person. Okay. So this is known as obesity hyperventilation syndrome. You know all about that. So what happens is you have increased thoracic load. I mean, you only have so much muscle. So your muscles have capacity. I mean, seriously, David looks like a guy that does some exercise and things in his brain. Even at that, there is a maximum weight he could lift with his biceps. He has the maximum. Everybody does. Right?
Just has no limit.
Yeah, believe me, it does. I don't even think you can beat me in arm wrestling.
Ooh.
I'm challenging you right now.
Oh, come on, Justin.
Okay, so, every muscle has a limit. So you only have so much thoracic muscles and intercostal muscles. When you pile, and when you gain weight, you don't gain weight in your chest. Your adult thoracic cavity does not increase because you get fat. It stays the same. So think about it. If you were born with a thoracic cavity that looks like this, and you had skin, and somehow you moved to Los Angeles, and now your thoracic cavity is still this, but now your skin is here. Well, think about that. The intercostal muscles now have to push in expansion against this fat. And when you go to bed and you lie on your back, gravity is going to crush your chest with this fat. And then heaven help you if you are busty as a woman. Right? Then you really have problems. And many times patients with these problems will not be able to sleep straight on the bed. They have to use like 4 pillows. So when they come to tell you, I sleep with 4 pillows, ask them, why do you sleep with 4 pillows? Oh, because I breathe better. Is it because you shut up breath when you lie flat? You have to tell it, because that could make you start thinking that you have heart failure. Right? Because you will present like autopsy. But that is not autopsy. It's like patient with GERD. They do the same thing. They sleep with many pillows. It's not everybody that sleep with many pillows that has autopnea. Right? You could have autopnea because you have a lot of weight on your chest, or because you have sedation, or because you have GERD. Alright? So because of that chronic hypoventilation, they tend to retain CO2. They're not able to exchange air effectively. So they hold on to carbon dioxide. Right? Of course, I told you before that your respiratory center is wired to respond to your CO2 level, right? That's what it does. So if you are retaining CO2 acutely, your respiratory center will stimulate your breathing faster because it recognizes that you're retaining CO2. But if you retain CO2 long enough, your respiratory center becomes numb to your plasma CO2. Then we say you lose hypercapnic drive, and now you have an hypoxic drive. So instead of the respiratory center using your carbon dioxide to monitor your respiratory needs, because you kept holding on to carbon dioxide, he recognizes that I cannot use carbon dioxide anymore in this guy. He's piling it up for whatever reason, and I don't know why. I have to depend on oxygen. He now starts using oxygen level to determine whether to stimulate breath or not stimulate breath. And that is when the patient becomes a danger to you. Because when that patient with hypoxic drive now comes to you, and your heroic clinician, you slam oxygen on his face, he's going to stop breathing right there under your face. Because you just supply enough oxygen and the respiratory center will be like, oh, you have so much oxygen you don't need to breathe. That is why we don't give COPD patients a lot of oxygen. We only start with 1 liters per minute, go up to 2 liters per minute. And you keep watching them closely. Because most of them have hypoxic drive, not hypercapnic like everybody else. Okay? So, how does Pickwickian syndrome present? Nighttime sleeplessness. Why do you think they're sleepless at night? Because they can't breathe when they lay flat. Right? They have nocturnal hypoxia. And because they cannot sleep at night, they become sleepy excessively during the day. Right? So they have excessive daytime sleepiness. And some people think it's because they're retaining CO2. They call it CO2 narcosis. I don't think it is CO2 narcosis. I really believe they are sleepy during the day because they couldn't sleep at night. Okay? And when you look at them, they have BMI excess of 35. That is very polite. Most of them have BMIs above 40. Okay? Some of my patients are so overweight that the clinic scale cannot measure their weight. Because you know, the clinic scales usually don't measure above 350, right? I have patients that weigh like 400 pounds. And I have to get them to come over here because we have a scale here that can measure up to 500 pounds. And you know what is amazing? What is amazing to me is some of these young women, 450 pounds, 460 pounds, with incredible figure 8. And they have normal blood pressure, normal blood sugar, normal cholesterol. I'm like, how are you doing this? I wish there's a way we could take your genes and figure out what is it about you that allows you to gather so much adipocytes without the morbidity of it. The only way I get them to begin to think about it is like, you know, you're 36, it's okay to look like this and be feeling cool. If you maintain this weight until you're 40, you're going to start getting real sick because your knees are not going to be able to carry this weight anymore. Now is the time to do it. And I give them very light goals. I just did it on Thursday. I'm like, why don't we start with 1 pound a month? Like 1 pound a month, that is nothing. I need to lose like 600 pounds. I'm like, I know. But I'm not going to get you to lose 60 pounds. Let's just start with 1 pound a month. Because in most of my patients, I'm stuck with them for like years. The newest patient I have in my practice is like 5 years. Most of my patients I've known for 10, 15 years. So I know I can. With 1 pound, if I just get you to agree with me, 1 pound a month will do it. And especially if I know you drink a lot of sweets and sodas, oh, that is even easy. So let's just start out with cutting out sweet liquids, period. If it is liquid and sweet, no more. Just water. Oh, but I like sweet, but then take 0 Coke or 0 whatever. But no more sodas. I've gotten patients off of diabetic medication by just getting them to stop drinking sodas. So I know it can work. Oh, okay, so let's start with that. I'm like, okay, fine. But 1 pound a month is kind of small. I'm like, that's okay, but do you know what that could mean? 1 pound a month is all we need for you to lose 12 pounds a year. If I can get you to do that for 10 years, consistently, that is 120 pounds. You will be grateful you did that for yourself in 10 years. That is so easy to do. You know, they now get on board, and many of them have done it. Many of my patients have done it. I've had patients that have lost 50 pounds over 10 years. Some have lost 60 pounds over 10 years. And they look back and like, they didn't even know how it came off. That is a different attitude than walking into the room and looking like you're morbidly obese. You need to lose weight. Hello? have my blood pressure. I don't need you talking to me like that. You know, don't do that to people. Like that, I don't know if you watched that YouTube video, that woman that was sitting between these two, one black guy and one black woman. They tend to be a little bit heavy set, and she had to sit in between them, and she refused to sit in between them. Okay, and she asked to be reseated because she was going to be squashed in between them. Okay, fine, it's okay to ask to be reseated. But when she was now being reseated and getting up, you know what she said? I eat salad. And seriously, you eat salad. If that is true, then there should be no overweight vegetarian. Just because you eat salad does not mean you believe. I mean, seriously, I have patients that are vegetarians that are morbidly obese. But just the insensitivity. You know what was cool? What was cool was that everybody in that cabin, white, black, Latino, everybody rose up to condemn what she did, and she was ashamed. You know, that is the America that I know. You know, we cannot afford to have people mistreat other people for no reason. There is no reason for it. You know, it's okay, yeah, you know, you paid for your flight, you don't want to be squashed. That's okay, I agree with you. But you could be very polite about it. Because the truth is, let me tell you something. If that plane is to go into some severe turbulence, you will survive because you're sandwiched between two
Chicken sandwich.
You know. So, and of course, when you do a blood gas, you will see type 2 respiratory failure. And you remember type 2 respiratory failure has only two causes, right? COPD and hyperventilation. And the difference is normal AA gradient, right? So this guy will have type 2 respiratory failure with normal AA gradient. Of course, you will evaluate him because you will see erythrocytosis because of his chronic hypoxia, right? He's going to have erythrocytosis. If you do his EKG, well, what would you see on his EKG? If you do an EKG on somebody with Picquet syndrome, what would you see? Thank you. The voltages will be low because the distance between the heart and the skin is a lot in morbid obesity. So this right ventricular hypertrophy and right atrial enlargement, you have to do a magnifying glass to see it because the voltages will be low, right? Because remember, for right ventricular hypertrophy, you're going to see an R wave in AVR, right? And for right atrial enlargement, you're going to see tall, peaked P wave, right? But if the voltages are generally low, that may not even be obvious on the EKG, right? Good. And if you do pulmonary function test, you will see the restrictive lung disease pattern. X-ray will be normal because the problem is not in the lungs. So it's not going to be COPD. All right, how do you treat it? Weight loss, weight loss, weight loss. Respiratory stimulants, usually in kids. Theophylline, progesterone. You know why we use progesterone? Progesterone stimulates the respiratory center. That is why pregnant patients, they overbreathe all the time. There is a chronic respiratory alkalosis that is associated with pregnancy because of the stimulatory effect of progesterone on the respiratory center. We'll talk about that in the summer. All right? And then when they are sleeping, you might give them nighttime positive pressure ventilation. You know what that really means? You know what nighttime positive pressure ventilation is? Normal ventilation is a negative pressure ventilation. Remember, air goes into your lungs, not with a positive pressure, but with a less negative pressure, right? With inspiration, your pleural space pressure does not, with respiration, your pleural space pressure does not go from positive to negative. It goes from less negative to more negative, right? So in these patients, because they have this weight on their chest, you now have to use a positive pressure to splint the airway against the compression weight. You get what I mean? You use positive pressure to keep the airway open, basically splinting the airway open against the crushing weight of the fat on top of the chest. So that's really what positive pressure ventilation is. Okay? You got that? Excellent. How many more slides do I have?
15.
15 slides. You guys want a break?
Yeah.
All right, okay, go. You hear about it a lot, right?
Mm-hmm.
Sleep apnea is a sleep disordered breathing characterized by brief in the sense that it's less than 10 seconds. More than 5 times per hour. So there are brief pauses of breathlessness and or periods of shallow breathing, hypopnea during sleep. So please understand my definition here, because I was putting a definition within a definition and it's making it complex. Sleep apnea is sleep disordered breathing characterized by brief pauses of breathlessness and or periods of shallow breathing during sleep. Breathlessness is known as apnea, shallow breathing is known as hypopnea, and brief is more than 10 seconds, more than 5 times. Actually, less than 10 seconds, more than 5 times. So change that. Is brief less than 10 seconds and more than 5 times per hour. Okay, that is the definition of sleep apnea. There are 2 types of it. There is the obstructive, which is really 90% of the cases, and there is the central, which is about 1% of the case, and mixed, which is about 9% of the cases. We'll talk more about the mixed, because you know what is interesting? Obstructive is usually due to airway obstruction, right? So you have, it's common in males, obese, history of rhinitis, sinusitis, there's a polyp, septal deviation, microdactylia, that is small mandible, macroglossia, large tongue, tonsillar hypertrophy, adenoidal hypertrophy, large neck. You determine that with the neck circumference, I'll give you the number. So all of this is obstructive, right? Central, so this has to do with airway obstruction. Central has to do with problem with your respiratory center. Okay, so central tends to be also known as chain stroke respiration. Is caused by intermittent insensitivity of the respiratory center and or the peripheral chemoreceptors to oxygen and carbon dioxide level in the arterial blood. So what this central is really is characterized by alternating cycles of apnea and hypopnea, and is associated with strokes generally. So you see what happens is that, oh, you remember sick sinus syndrome, right? When the SA node goes limp and dumb for a while, and then wakes up and tries to catch up. So put the patient between tachybrady syndrome, right? That's exactly what chest is. It's exactly the same kind of phenomenon, but only this time happening in the respiratory center. So the center becomes numb and does not respond to falling level of oxygen and rising level of carbon dioxide, and all of a sudden it catches itself and tries to catch up. So the patients alternate between hypopnea / apnea to hypopnea. So alternating like that. That's what I'm trying to tell you here. Characterized by alternating cycles of apnea and hyperapnea. Okay? Usually associated with strokes. And 9% of the time it is sleep. It is mixed. So the way you diagnose mixed is usually like this. So you have a patient that comes in with sleep apnea. Or you recognize it because patient comes, they have Pickwickian syndrome usually, right? But not always. So it tells you, I lost my job. He was a security guard in Rams, and he lost his job because he was falling asleep on the job. Then it's like, oh, you need to lose some weight. This is probably sleep apnea. And then he has hypertension, he has diabetes, he has had a stroke, but he's able to recover from it. and he's walking now. Now you fix his obstructive apnea, then you find out that he's still not able to sleep. So what that really means is that, well, what he really had was mixed. It was not just obstructive. So generally speaking, mixed apnea means there is obstructive and a central component. But invariably, the central component does not manifest until you fix the obstructive component. Okay? So that is how that works. Okay, I'll look at all the causes of obstructive. Everything we talked about in the airway, right? Upper airway especially, right? I don't know why men have the issue. So, how does it present? Well, in terms of symptoms, you can have general symptoms or specific symptoms. The general symptoms are restless sleep, nocturia. Can anybody tell me why they have nocturia? Why do they have nocturia, Ashton? Ashton. I like it. Why do I do this? Ashton. Why do they have nocturia? Sorry. You don't know? Want me to help you?
Yes.
Remember ANP, atrial natriuretic peptide? Right? It's in the right atrium, right? Whenever you increase pressure to the right atrium and you distend it, the autonomic nervous system translates that as polymobility, right? And it will release ANP. And ANP is the most potent diuretic known to mankind. So let me ask you, if you're in a place that somebody has morbid obesity and you think they have sleep apnea, but you don't know how bad it is, if you look at their day-overnight urinary frequency, you can have an idea of how many hypoxic episodes they get in the night. Because every hypoxic episode will trigger the release of ANP. And ANP is a diuretic. So they will get up to go and pee. So if your patient that has morbid obesity and looks like he is having sleep apnea, tells you, I get up 6 to 8 times to pee, that patient is going to die in his sleep if you don't do something really quick. As a matter of fact, I'm working with the UCLA Sleep Study Center now to correlate findings of sleep studies with just patient history of nocturia to see how specific and sensitive is the history of nocturia in patients with sleep apnea. Because it really can help. Look, whatever your patients can tell you that helps you make a diagnosis, you should know it. Because you're going to be in areas where patients can't afford or cannot get what they need, and you still need to be able to make this diagnosis. Okay? So that is why they get nocturia. What is their name?
Crystal.
Crystal! I know, you know, the truth is, your pictures on those walls, you guys are all made up and everything. Now you're all weather beating, and I cannot tell people apart. Crystal. Okay. So I'm going to pick on you for a few lectures so I can get used to it. Okay, so you see this A and B. That is why they have nocturia. So one of the things you must do when you're reviewing patient symptoms, when you're taking their history, is to ask them, how often do you move your bowel? You must ask them. No constipation, no diarrhea. Patients open bowel daily. Some people open bowel weekly, some every other day. You won't believe how much variability there is. That is why we cannot define constipation. It's so difficult to define constipation based on frequency of stooling. We define constipation based on the form of stool, not frequency, because the frequency is crazy, right? Did Kat tell you any frequency for constipation? You guys did GI, right?
Yeah.
Did you guys talk about constipation?
Yeah.
Did they give any frequency for it? No, that's why there's no frequency for constipation. It's form that we use, no frequency. Diarrhea we can talk about. Even diarrhea, we can talk about frequency because most of the time the frequency and the volume of the stool go together with diarrhea. But constipation is crazy. There's no frequency. Talk to people that eat a lot of vegetables, they move their bowels daily. Some people move their bowels multiple times a day, and that is normal, right? So, one of the things you must ask is how often do you move your bowel, and how many times do you pee? During the day and at night. Day, overnight, urinary frequency. And generally the way you should record that is just put D over N 5 over 0 to 1. Okay? Whenever people begin to get up more at night to pee, and the bottom number is approaching the daytime number, two things is happening. There are edematous, like in nephrotic syndrome, heart failure, right? Or even right heart failure. So that when they go to bed, gravity returns blood to the heart, and cardiac output increases, and they pee more. Or they are getting hypoxic episodes in the night and releasing A and P and going into the bathroom, right? So these two things you must remember that. And the only clue and then they have diabetes, right? In diabetic patients, the day overnight frequency is the same because they keep going, getting up to go. Polyuria, that's what polyuria really is, right? And polyuria patients may not even complain to you because they make excuses. They don't think it's a problem. What is wrong? I'm peeing a lot. It's not a problem. I think pee is waste, right? That means I have a lot of waste to get rid of. So they may not even recognize it or register it as a problem, right? So pay attention to the overnight urinary frequency, okay? When you're reviewing the system. All right? Then daytime sleepiness is what you see. Now, secondary manifestations are complications of the hypoxia. So somebody tells you, my husband just had a seizure in his sleep. He never had a seizure before, but he just had it in his sleep. And the guy is overweight. You have to think that could this have been an hypoxic episode in his sleep that triggered the hypoxia? Because you know what? If you don't diagnose that and you start putting him on anticonvulsants, you know what that will do, right? You will make him sleep deeper because anticonvulsants, they antagonize sodium transporting nerves, so they make the nerves less sensitive, right? You know what that will do, right? So if you put a guy with sleep apnea that develops a seizure as a result of an episode of hypoxia in his sleep, you now put him on dilantin, you make him sleep deeper. The hypoxia will not wake him up again. He will die in his sleep. You understand what I'm saying? Right? So understand that very well. You must be able to separate the secondary manifestation of apnea from the primary manifestations. Okay? Then angina, again, if the guy, of course, if the guy is overweight, most of the time, women get away with overweight. Okay? There are many women that are like seriously overweight and they're healthy. There's nothing wrong with them. I'm yet to see a man that is morbidly obese and healthy. I've not seen one man that is morbidly obese and healthy in all of my 25 years of practice in Los Angeles. I've not seen one male patient that is morbidly obese and healthy. But I've seen tons of women with morbid obesity and completely healthy. Okay? So if the guy has morbid obesity and he goes into hypoxia and is hypertensive diabetic, then he goes into hypoxia when he's sleeping, he might wake up with chest pain, right? Because he has a baseline coronary artery disease. Now you reduce, because hypoxia, you precipitate chest pain. You might even precipitate arrhythmia, right? And you might have a heart attack at that time as well. Okay? So, very important. Of course, the only specific symptom of sleep apnea when it's obstructive is stertor. That is the fancy name for snoring. Okay? Stertor. And it's very specific for obstructive kind. So snoring is not a sign of, it's not a general sign of sleep apnea, no. It's a specific symptom of obstructive type of apnea, of sleep apnea. Let me say that again. Snoring is not a generalized symptom, or it's not a general symptom of sleep apnea. I'm having tongue tie. Okay, but it's a specific symptom of obstructive sleep apnea. So if somebody has central sleep apnea, they will not snore. Okay? And if, yeah.
So, does everyone who snores have obstructive sleep apnea?
No. Snoring is a manifestation of obstructive sleep apnea, but not everyone who snores is having sleep apnea. That is the reason for my study that I'm trying to do with UCLA students. To actually figure out how specific is snoring for sleep apnea. Oh, I snore like hell, but I don't have sleep apnea because I'm not sleeping when I'm talking to you, right? But if somebody, if your wife tells you, my husband started snoring after his stroke, that is weird, right? Because stroke is supposed to cause central sleep apnea, right? And snoring is supposed to be a manifestation of obstructive sleep apnea. So if I ask you, if a wife tells you that my husband started snoring after his stroke, where was the stroke? Is it a cortical stroke or a brainstem stroke? Guess. Brainstem. Because he has a brainstem stroke where all the cranial nerves and the muscles of the larynx and everything are supposed to be coming from, and he has a weakness in those nerves, and the airway is now losing tone. It collapses. You could get in inspiration. You could develop obstruction, right, as a result of a brainstem stroke that may not have anything to do with the respiratory center. You understand what I'm saying, right? You get that?
Yes.
Okay. So, signs. You look at the patient, you see nasal obstruction, you will see micronatia, tonsillar hypertrophy, you can see macro or retronatia, you can see large tongue. You see, this is macronatia right there. You see obesity, officially defined as BMI more than 30, but patients don't come to you with sleep apnea at 35. In fact, I have a paper out there somewhere where I showed that obesity does not become truly morbid in people over the age of 65 until their BMI is more than 35. And that was way before they classified BMI 35 as morbid obesity. Because I was looking at old people in their age. I'm like, okay, let's look at it. Because the reason I did this study was because in Africa, we believe that weight gain is a sign of health and wealth. In many rural cultures, that is the way it is looked at. When you gain weight, that is when you've arrived, right? You're still struggling when you're lean and slim, right? So I'm like, could that be wrong? And also, if you look in the Bible considers fat as being blessed, you know? Like, so, and I am still waiting for the day I'll find the Bible wrong in anything. So I said, let me go look in the national data set and see, was the Bible wrong when it says people are fat or are blessed? It turns out, yes, actually the Bible is not wrong. When you are older, right, extra weight helps you live longer, right? We used to call it obesity paradox, but people are challenging it now. They say the reason we see obese elderly live longer is because the obese sick people die early. You understand the logic, right? If sick obese people die early, that means the obese people that are living older were healthier from the beginning. They are not living longer because of obesity, but they're living longer because they're healthier. You understand what I'm saying? So that is being challenged, but I don't buy it. I just don't think so. I just think that, because I also know that in dialysis, if you end up on dialysis, how long you live on dialysis depends on your weight when you go to dialysis. If you're obese, when you go to dialysis, you live longer. If you're ideal weight, when you get on dialysis, you live less, you live shorter. Right? So I mean, and remember, this obesity thing did not come from the health industry. It came from the insurance industry. And what the insurance data showed was that if you carry more than 20% of your weight in extra, in fact, you cost them more money. So there is a level of obesity that is compatible with health. Our current classification is based on the American model industry, not really based on health data. You know, I don't talk much about this because I really don't want anybody to walk away with the impression that I'm saying that obesity is okay. You know, but this is what I use to moderate the way I approach my patients with obesity. Without encouraging them to maintain ideal weight, gain weight, but when your BMI is over 30, I begin to holler. When it goes over 35, I'm screaming. Every time you see me, you talk about this weight because I can't afford to have you keep gaining weight. And I tell my patients all the time, if you don't want to lose weight, it's okay. But you cannot gain weight under my watch. Then I'm failing. I feel like I'm failing. I mean, you know, it's interesting. Patients respond differently to that kind of approach than you being a taskmaster. You know, my job as a healthcare provider is to help you be the healthiest you can be. If you gain weight under my watch, then I'm not doing what I'm supposed to. That's how I feel. And then so now they feel like they want to help you, right? And people always are more motivated when they feel they're helping you than you standing over them to help themselves. You understand the logic?
Yeah.
So, when is your neck large? If you're a woman and your neck circumference is more than 16 inch, or you're a man and your neck circumference is more than 17 inch, I'm going to measure all of your neck circumferences at the next physical diagnosis. So, that is what large neck is. And of course, if a patient they walk into your room like that, on a stroke, right? So if there's going to be sleep apnea in that patient, it's got to be a central sleep apnea, right? That will help you, man. Who really suffers when the guy snores? It's the poor spouse right there. Look at her, she's so helpless. Like, this one is so like, what am I going to do? We both have to go to work in the morning. Right here is really bad, right? And poor guy, they don't know. What can you do, man? How do you evaluate sleep apnea? Of course, you do your basic test. You do CBC. You're looking for secondary erythrocytosis. That is a marker of how long this has been going on. Because remember, you don't develop erythrocytosis in 6 months, not even in 1 year. So if you see erythrocytosis, secondary erythrocytosis, that means that patient is not only having sleep apnea, but they're actually having chronic hypoxia that has been going on for so long that the bone marrow is now responding to it. Okay? So it's you know the way we do with hemoglobin A1C to see how long your sugar has been out of control, right? Same with secondary erythrocytosis, it's an index of chronicity. Okay? And of course, you see your basic metabolic panel, you will see metabolic alkalosis. Why you see metabolic alkalosis? Because it's compensating for respiratory acidosis. Right? You remember the Anderson-Hasselbalch equation? You did that in your physiology, whatever physiology class you took. We'll talk more about this in endocrinology, but I'm sure you remember that carbon dioxide, carbon dioxide, right? You remember that carbon dioxide dissolves in water and gives you carbonic acid, and carbonic acid dissociates into hydrogen ion and bicarbonate. You remember that? Good. So if somebody is retaining CO2, at the end of the day, what you will see in your blood is elevated carbonic carbon dioxide, right? So that is why you can have metabolic alkalosis based on that. And because thyroid function test is important, because hypothyroidism can be a cause of obesity, right? So, and if your patient is obese because they have hypothyroid, my goodness, can you imagine? That is good news. Because that means that weight can be gone in under a year with thyroid replacement. So you always screen your patient with for thyroid function test. And then you also see if they have growth hormone level for acromegaly as well. But before you do growth hormone level, what must you see in a patient with sleep apnea? Because remember, in acromegaly you have prognatism, right? And that can create obstruction, right? So what would you see in your patient? Look at what you see. See this woman's teeth? See all the space in between it? Yeah, that is how you recognize that this jaw has increased. Because when your jaw size increases and the number of your teeth does not increase, you end up with spaces in between your teeth, right? And we call that prognatism. That's what you see. And because your teeth are stronger when they are connected and joined together than when they are single by themselves, these patients tend to lose teeth, okay, because the teeth are not supported by themselves, okay? And then you look at the tongue. Everybody should be able to put out their tongue and say, that ancient practice is so important. Don't let it slip through your fingers, because nobody is doing it anymore. You know, in those days, you go to the doctor and say, open your mouth, and they say, just keep doing it. Because you know what? If somebody has macroglossia, right? If they have macroglossia, if their tongue is bigger than it should be, you tell them to open their mouth and say, you will see that the tongue will fill the entire mouth. So you can't see the back of their throat because the tongue is huge. And macroglossia is a big deal. You don't want to miss it, right? So very important.
Professor, sorry, what was the widening of the jaw called?
Prognatism. 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 And then you look at the EKG. What am I showing you on this EKG? What am I showing you on this EKG? Can anybody tell me what is on this EKG? Yeah, there's an inverted T wave, but there is something more unusual. Look at that R wave in V1. Is that what you expect? No. You expect R wave to be really small in V1, right? And then you can see that there's a right axis deviation here, right? So this patient has a right ventricular hypertrophy, right? Which is part of what you see in acromegaly, right? Okay. So how do you diagnose it? Well, don't be intimidated. It's a lot simpler now. We have simpler ways of doing this now. Because now they have, but this is the traditional setting. The patient has to go into the place and they have to do a test called polysomnography. Basically, many sleep recording. That's what polysomnography means. Many sleep recording. Right? So they have a patient here. They have a sensor at the nose that is measuring airflow. And then there is sensor on the face and scalp that is measuring eye movement and brain activity. They want to know if this hypoxia woke him up or not. And then there are wires transmitting data to a nearby monitor. There is an elastic belt with sensors around the chest to see if the chest wall is moving. And then there are sensors at the fingertip to see what is the level of the oxygen in the blood, your pulse ox, right? So all these many recordings. And then they come like this. So you have the electroculogram, EMG, EKG, and this is the standard location on the scalp. And you get all this recording: pulse, chest, airflow through the nose. Did the patient snore? Did the leg move? Did the heart respond? These are the brain activity. Did the patient wake up? Because these have sleeping pattern and awake pattern. Very complex recording, but ultimately to analyze it, this is what you really need. You only need an indication for flow. You need a reading for thoracic effort. You need a reading for abdominal effort, right? So if while you're looking at the strip, you see an area where the patient had no airflow, right? So it's flat, right? That means the patient stopped breathing it, right? And then you see that, well, the patient stopped breathing, but not because there was no movement in the thorax. The thorax still moved. There was still some abdominal effort, but air did not flow. Then they said, this is obstructive, right? Because the patient made the effort, right? From here. But then you look at this reading, you say, okay, airflow ceased. There was no effort. That is a central pattern. So even though you get all this complicated reading, you don't need all this complicated reading to make a decision. All you need is just show me the one that shows the flow and the thoracic effort. I can tell you whether or not the patient has a central sleep or obstructive sleep apnea. So in your exam, I'll put this up there, right? So you must be able to tell from a simple reading whether the patient has a central or obstructive sleep apnea. Okay. Is that difficult? Would that be hard?
No.
Okay, thank you. So,
does this test require sleepover?
oh yes, yeah. That's why it's so expensive. Almost, depending on where you go, it goes from anywhere from $3,000 to $15,000. Usually it's overnight, yeah. Because a tech is there. A tech is there, and you have at least one physician there overnight with that patient. Because things could go wrong. All right. But now they have simpler measures. You can actually do it at home now. They have home kits that uses only the airflow meters and the pulse ox. Because that's really all you want to do. You want to know hypoxia with airflow. And then they put another one in the chest.
Okay.
So they have 3 pointers. And it's a device, portable now. But this is the traditional one, sleep study centers. Okay, that's what they do. All right, you got that, right? Excellent. Now just some definitions. Apnea is reduced airflow to more than 80%. Hypopnea, reduced airflow to between 50 and 30. Both of them will give you the saturation. Apnea lasts for more than 10 seconds. More than 10 seconds, at least 10 seconds. Less than 10 seconds, at least 10 seconds. I don't know why everybody keeps putting greater than 10 seconds here. Apnea will always end up in arousal, may end with arousal. And then you calculate, you know what, I'm giving you this for information only. Okay, this is not, don't bother your head with it. Okay, you're not going to deal with this. This is just for you to know what they will do. If they report to you that the apnea apopnic index is this, or they tell you respiratory disturbance index, just for you to know what those numbers, where they come from, okay? So, that is how we define the severity of sleep apnea. The number of events per hour of sleep, you can define it with apnea hypopnea index or respiratory disturbance index. Normal, all of us, we wake up in the night. Some people wake up from bad dreams. Some people wake up because their head was like that and they wake up. So, but generally speaking, most of us wake for less than 5 times in the night, you know. If you have to wake 5 to 15, 14 times in the night, 15 times actually, that is mild. Moderate is 15 to 30. 0.9 is what they use officially, but I think it's easier to remember if you just say 5 to 15, 15 to 30, and more than 30. That's my approach to it, okay? Now there is something you must remember. The loudness of the snoring is not an indicator of the sleep apnea or the severity of it. So your question, you know, some guys, no, that does not mean you have sleep apnea, you snore loud. No, the loudness of the snore does not matter. Okay, it's not an indication. So don't go bother people. Okay? So I saw this American College of Cardiology sleep apnea stuff. I think it's cool. I mean, to put so much information on a single slide like this is remarkable. Everything there is really important. Okay? Sleep apnea diagnosed 10 seconds longer than 5 times per hour. Men are more likely to be affected. People with sleep apnea, see what happens? More likely to die from sudden cardiac death. You know that's what happens, right? You go into hypoxia while you're sleeping, go into arrhythmia. If it happens to be a ventricular arrhythmia, you die in that sleep. Nobody figure out what it is. Okay? And then people with obstructive sleep apnea, sudden cardiac death is more likely to occur between 10 p.m. and 6 a.m. Right? Actually, it's more specific than that. Do you know why people die in the early hours of the morning between 3 and 6? Because remember circadian rhythm? When you're sleeping, everything shuts down. Your hormones, your growth hormone, your catecholamines, they are suppressed when you're sleeping. At about 3 o'clock in the morning, you know, your engines start revving, trying to wake you up. That is when your cortisol, catecholamines, everything begin to rise again. If you're vulnerable, that is when you're likely to die. That's why you notice that ambulances are always running the streets between 3 and 6 in the morning. Because that is because of the circadian rhythm. Most people with cardiac event, if you're going to die of a heart problem, you're going to die between 3 and 6. Okay. So, it is more specific than 10 p.m. and 6. It's more like 3 and 6 a.m. Okay? And then in general population, people die between 6 a.m. and noon, right? In general population, if you don't have heart disease, right? 12 million Americans diagnosed with it, and many of them are undiagnosed. A significant cause of sudden cardiac death. Look at it. Almost 500,000 deaths every single year. Okay? Very important that you pay attention to it. Screen for it, talk about it, encourage your patient to lose weight. Do it all the time in the most polite way you can do it, so you don't fracture their ego, and they will still come back to see you. All right? So you make them feel like they're helping you by losing weight. Okay? And you have to be balanced for you to take that on. Many people are so sensitive to blame, you know, or some people are so arrogant that the idea of somebody helping them is not acceptable. You know, you've seen people like that. They cannot accept the fact that my patient is going to help me. Okay. If you feel like you're helping me by losing weight, that will make you healthy. Hey, help me. And I hope you're all going to be humble people that will go out there and help humanity. You know, whatever that costs you. A little scratch on your ego will fix somebody's ego. Hey, who's my ego? Not that much. Okay, so let's go. How then do you treat it? Well, you start with, as a clinician, this is what you will do. This is where you will learn with me. Postural changes. You're going to do better on your feet. So prop your head up so you can resolve some of the weight horizontally so it doesn't compress your chest, right? You're short of breath, get up on your feet. Lay on your side, because when you lay on your side, you reduce your surface area to gravity, right? I can push David better like this than I can do like this, right? So when they lay on their side, the surface area that is under the influence of gravity is narrower. So the chest wall is less compressed, right? Than when they are like this. When they are like this, the entire diameter of the chest is on the lungs. So sleep on your side. right? And for heaven's sake, let's start doing some weight loss, okay? And then there are orofacial exercises that physical therapists do. And then they have all these breathing devices, right? Mouthpieces that can reposition the mandible, restrain the tongue. They have pressure devices like nasal expiratory positive airway pressure devices. They call it nasal EPAP. There are surgeries that can pull the tongue forward, and there are equipment like nighttime positive airway ventilation that we talked about. But I told you, splint the airway against the compression from the chest wall. So all of these devices, unfortunately, plans don't pay for any of this, right? You're gonna have to just make do with these two right here. Most of your patients, this is what you really need. Most importantly, weight control. Whatever you have to do to help that patient lose weight. And the commonest reason for weight loss, for weight gain in this country is the consumption of sweet liquids. Sweet liquids. See, all of you, see, look at you, carry all these cups. I'm sure it's all sweet liquids. Very few of you have water in there, right? But it's okay. You're in school and we're stressing you. I can understand that. You probably gain a couple of pounds before you graduate. But you will lose it all in practice, believe me. You know, provided you don't take the cup into the exam room. Yeah. So, in terms of evaluating why are people overweight, start out with, do you drink soda? Most people do. Okay? And you really have to make a conscious effort to really cut that down. Sweet liquids. I just call it sweet liquids because it's not just about soda. It's about tea if you're using sugar. It's about all this energy drink, Monster, and all this crap that people drink to keep awake, energy. So people call it my vitamin water, but it is sweetened. Forget all that. Take a multivitamin tablet. You don't have to drink it in sweet liquid. Take the tablet, right? And then the next thing is all those sweets, cakes, cookies, candy, pastries, everything from the panaderia, right? And you say all those things, everything, man. Talk to patients about it and you'll be surprised. You know, there is this, do you know the people with the sweetest dessert on the planet? Indians. Indian desserts are so freaking sweet. Man, when you put that stuff 2 hours after eating it, it's still sweet in your mouth. I don't remember the name of it, but there was one particular one that is small and whitish like that, and I went, it's like little brown balls, and yeah. You take one of those things, man, and even water becomes sweet for so long. I'm like, man. So, you know, just explore, talk to people, and you'll be amazed at what, you know, the area of the greatest innovation for us as a people is in food. You know, that was why I hated it when that guy committed suicide in England, because he was exploring this world for food. Humans, there is no other area that we have explored and been so innovative. Anthony Boledia. Yeah. You know, we've been so innovative as in food. My goodness, it's amazing. Rural communities, nothing but their hands and their brains. And they will take one little grain like this and do something to it. And by the time they present it to you, not only would you not recognize where the heck that came from, and then the taste is nothing like from this world. Like, who figured this out? Who figured out that if you put cassava in a place and when it's about to rotten, that's when you now bring it out and then grind it and dry it, and then you can make fufu with that? Like, who figured that out? You know? But talk to people about what they're eating and how they're eating it, and you'll be amazed that weight loss is a lot easier than we think. You don't need a gym membership. Exercise is the old-fashioned play. You know, girls used to do, and that's stuff they used to do like, it's the same thing. It's the old-fashioned play. You don't need a gym membership. Chase your kids in the pool and chase your wife around the pool. Exercise, right? It doesn't have to be in the gym and 4 o'clock in the morning and painful. No, it's the same thing. Make it fun. Now, this NPPV, nasal positive pressure ventilation, it has some problems with it, right? Because remember, you're putting positive pressure in the airway, right? And your ears are connected to your airway, right? And your ear, your nose, they're all in the airway. And remember, the nasolacrimal duct empties into the airway. So when you put positive pressure there, you're forcing this back onto the eye. So they end up with the red eye, right? So, and then because of the jet of air going through the conjunctiva all the time, the eye gets dry. Okay? What is the danger of dry eye? The cornea can ulcerate. If your cornea ulcerates and perforates, you go blind.
Go.
Okay. So you go from being short of breath to being blind. Because you have an ignorant clinician. That's why I'm telling you all these things. So you can only help your patients. You can anticipate disaster ahead of time. That's your job. See danger coming when it's miles away from your patient and warn them. Sometimes you can't help it, okay? The patient needs it, you have to give it. Then give them artificial tears and warn them. We need to lose weight, man. If you don't lose weight, you keep using this stuff, you're gonna go blind. Believe me, they listen. If you want a guy to take his blood pressure medicine, tell him, or his blood sugar medicine, tell him he will lose his erection if he doesn't control his blood sugar. He'll pay attention to you, believe me. And if you want a woman to stop smoking, tell her, you know you're going to get wrinkled really badly in your early 40s. Really? That gets their attention. Or your hair is going to start smoking. You know, high school kids, when I want to get them never to smoke, like if you smoke, you get in your hair. It gets in my hair, I say yes. All I need to do is just come close to your ears and I can smell your hair, and I know if you smoke, you stink. No woman wants to stink. You know, they will never smoke. You know, but if they're already hooked and they know how to perfume their hair, it's too late. So don't do that with adults. You look for something that you wrinkly. They listen to that one. All right. So you can also refit the breathing device to make it less. Basically, you isolate the nose from it, so you don't get the nasolaryngal ducts insufflation like you normally can. Surgery for sleep apnea. Information. Nasal obstruction, put a hole in the septostomy. Okay. Nasal septum deviation, that can fix it. Pharyngeal obstruction, take out the obstruction, remove the adenoids, take out the tonsils, fix the uvulopalatine pharyngeal. And you see, this uvulopalato-pharyngoplasty is when you have weakness in the pharynx in such a way that the pharyngeal wall collapses under the negative inspiratory pressure. So what they do here is to fix it. Basically what they do is they cause scarring. They cause scarring in the space so that the healing, the tissue becomes tough and scarred. And then it doesn't collapse anymore with inspiration. That's what the uvulopalatopharyngoplasty really is. Okay? And then higher suspension is for the tongues that are in the way. Then you have the maxillomandibular advancement. Look at it. This was this woman before, this is the woman after. And this surgery was done in India. All right? So this is all there is for surgery. And then for central sleep apnea, pay attention here. Because, you know, for obstructive sleep apnea, you only have weight loss. That's all you have, really. And tell the patient to sleep up or sleep on the side. That's all you have. The rest is surgery. And you won't do surgery. Most of you won't do surgery. But for central sleep apnea, you are the king. There's a lot of options you have to help your patient. So pay attention here. Okay? This is how you will get it. Brainstem stroke, Parkinson's, Alzheimer's. Well, ideally you should call it Alzheimer's, but because it's a German word, it's Alzheimer. You know the Germans switch V and we and W, they call this window, right? Stuff like that.
Okay.
So this is Alzheimer's, this is the real word. Right? Most people call it Alzheimer's, it's not really Alzheimer's, it's Alzheimer's. Right? And that's why black folks used to call it old timers disease. Actually, they are closer to the correct pronunciation than the so-called educated. Alzheimer's disease, multiple sclerosis, narcotic overdose, heart failure, hypothyroidism, kidney failure, all of this will give you central sleep apnea. How do you begin? Supplemental oxygen. You can do devices, continuous positive pressure ventilation, pressure support ventilation, bi-level positive airway pressure ventilation. You can do diaphragmatic pacing. You know pacemaker, right? You put pacemaker, we connect it to the air sailor, right? And it discharges time and again. Diaphragmatic pacing is exactly having a pacemaker, but this time it is connected to the phrenic nerve. So it discharges and fires the phrenic nerve to get the diaphragm to contract and get the patient to breathe. Okay? You don't do all that. Pay attention to this one. Theophylline. It's a very simple medication. It's available all over the world. It can help your patient with central sleep apnea. For under $1, you can save a life. That's why you cannot forget that. And then look at acetazolamide, Diamox. It's available all over the world. You can control the secondary metabolic alkalosis of central sleep apnea with Diamox. Okay? So I want you to pay attention to this one. If you miss sleep apnea, people die, okay? So please don't kill them by negligence. Look out for it, diagnose it, respond to it. Don't stop hollering until that patient loses that weight. All they need is a little nudge, believe me. People deal with a lot that is responsible for their weight gain. But all you need is just take the edge off a little bit and encourage them. Instead of seeing them every 3 months, most of my overweight patients, I see them every 6 weeks. Not because I need to see them every 6 weeks to control their blood pressure, blood sugar, no. But every 6 weeks, I get an opportunity to talk about the weight and whether or not they lose that pound in that last 6 weeks. You will get in trouble. HMO will say, this is called patient churning. You're doing it for making money. I'm like, call it what you want. Even if I write nothing in that chart, I will still see this patient. And you will still pay me because I monitor the weight. So if you're doing it for weight loss, put there that you're monitoring this visit is for weight check. So you get people off your back. If you don't specify, they will come after you. They'll say you're churning patients. And there are people that churn patients. Bring them in because there are plans and programs, federal programs that pay for uninsured people when they see doctors. And many doctors take advantage of those plans by bringing patients because they are visit-based reimbursements. So if you bring your patients 4 times in a year, you only get 4 times 360, right? But if you bring them on to you 10 times in a year, you get more money, right? But the truth is, you're not doing more. You're just bringing the patient back so frequently, you're not doing anything just because you want to make money. And you can do that. But I hope none of you will ever do that because that is blood money, okay? Because you're causing people to get on the bus more frequently, go home more, go out and in more often. And if they live in a bad neighborhood, every time they leave their house, there is a risk of death associated with it. And the more you bring them and take them because you want to make more money, the more risk you're putting on you. If somebody dies because they're coming to see you for a visit that is not needed, but you put them in because you want to make more money, you got blood on your hands. It does not matter what anybody else says. There are forces in nature that will make sure you pay back. Don't do it. Okay? So, but if you're going to bring them in sooner than they should come, indicate that your this visit is for weight check. Even if they just stop at the MA for the weight and you go in and say, oh, you didn't lose that 1 pound today. You planted it and they can go away. Go back home and you see them again in 6 weeks. It's a way to help folks do what they need to do. Okay? Do whatever you have to do because if you don't, see what happens. Early death, drowsiness, hypertension, heart attack, stroke, memory loss, diabetes, depression, insomnia. Everybody needs to sleep. Do whatever you can to help folks. They need help. Good. Any questions? Yes, Bradley?
With the weight loss, right, upon a month, how do you know it's like really legit true weight loss? Because people are just like, okay, I'm going that long, so I'm going to fast. How do you make sure they're really saying
No, I don't make sure my patients do what they're supposed to do. That's not what they're supposed to do. I agree with my patient on what they will do. And all I do is, did you do what you said you didn't do? Say, oh, I did it. Good. Or I didn't do it. Why? I didn't have time. You know, you never have time for anything you don't plan for. You know? So remember, it is very easy because when you're in practice, you see, especially as you grow older and you become more confident, and you're going to be very confident, and once you become confident, you become cocky. And it's going to take something from outside of you to fight back that, no, I'm not supposed to be cocky. If I'm going to help these folks, I can't be cocky. You must be approachable at all times. Your patient must be free to get angry with you and compliment you all the time. You're not always going to be right. And you want to know the earliest possible time when you're wrong. If you're not approachable, your patients will watch you until they get you in the corner and they'll scam you so hard. How many lawsuits does it take to sink a clinician? One. You're there to help people. You know, just come up with the same attitude and just don't overdress if you work in a low-income clinic where your patients cannot tell you because they're so preoccupied with your jewelry. My goodness, that watch, Dr. Martins, where is that from? You say, oh, I got it in Rome on my last vacation. Really? You get to go to Rome? Why can't I be like you? My friend, we're not here to discuss my watch or my shoes. We're talking about you. So I'm not going to come for you to have an opportunity to divert the whole clinic time talking about my shoes. You have to be conscious. These are not things that come automatically. Every day you leave your house, you know how you deal with anger? If you have anger issue, you leave your house that morning and you say, nobody will make me angry today. You speak it, you own it, and you leave. And then when you see that temptation coming, you will remember, you're not going to make me fail today. You are not the one that will make me get angry today. It's a beautiful way to live. You will live long. You will not have mood swings. And believe you me, you'll be happier and you'll be healthier. What good are you as a clinician if you're not healthy? The patient is coming to see, what happened, Dr. Martin? He's been controlling people's blood pressure all this year. How did he get a stroke? I don't know. You know, but if you're always bickering and bitching about the double book me, why? Half of the patients won't show up. Wait to worry. Why you get your this? I have colleagues in the clinic. We get to work 1 o'clock in the afternoon, and I'm looking at my schedule like 18 patients in 4 hours. I know about a third of them will not show. But then some of my friends will come. Like, David, like what? 18 patients. I didn't have it. He's sweating, he's tachycardic, he's red in the face. I'm like, Lawrence, come on. About a third of them wouldn't show. And moreover, once it is 5, you clock out. It's their business to figure out how these patients are going to be seen. Why are you killing yourself? And then at the end of the day, by 4 o'clock, half of the patients on the schedule did not show. And it's like, baby, you have anybody I can help you with? I'm like, yeah. Then he will take 2 of my patients. I'm like, so what was all that about? You see, every time you get angry, you die a little. No, I mean it. Because you see, every time you get angry, you release catecholamines. It takes seconds for them to flood your system. They will make your blood pressure go up, make your blood sugar go up, make you hypervigilant. In microseconds, that's how it takes to release them. You know how long it takes to glide out of your system? 4 hours. So think about it. So if you get really agitated every 4 hours, you never get a chance to recover from the anger. That is how people get chronic hypertension, diabetes, weight, all these problems. Why do you don't need all that? Especially from other people. People are crazy. What are you talking about? Why would you let people make you angry? That is what they do. They make God angry. And you are not God. So why are you so frustrated with people making you angry? That's what people can do. You know? Anyway, I'm preaching now. Let's do some questions. Okay. So last, match this very quickly. We don't have a lot of time. Maestro Gravis, what do you have here? Did I talk about this?
Yeah, you did.
I did, okay.
So executive paralysis would be like,
All right.
would be like.
Last, let's go. Good. Lambert Eaton? Lambert Eaton? Okay, let's talk about descending paralysis. Botulism, ascending paralysis, Guillain-Barré, motor neuron disease, Lou Gehrig. Okay. Which of the following is a risk factor for central sleep apnea? Stroke, right? So which of the following is a risk factor for obstructive sleep apnea?
Large neck.
Large neck, exactly. All right. So Christian Willard. 68-year-old male, hypertensive with a history of stroke. New onset generalized seizure, 1 episode. Witnessed by wife the night before during sleep. Review of system is negative except for snoring and day overnight urinary frequency 2/4. This guy pees more at night than during the day. That's a problem. Past medical history is significant for stroke 5 years ago. No family history of seizure disorders. He's a life-oriented. His BMI is 26. So the guy is already overweight. Blood pressure is uncontrolled. Physical examination is unremarkable except for the baseline mild left hemifacial paresis. CT scan of the head, old ischemic infarction. And this is your sleep study. What is your most likely diagnosis here? This is his airflow, this is respiratory movement, abdominal movement. So your decision is going to be made based on airflow, ribcage movement, and abdominal movement.
So there is movement.
Okay, so there is no, when there is no airflow, there is movement in the ribcage.
So it's central. I mean,
Obstructive.
Exactly. Good. So this guy has an obstructive sleep apnea. Okay? Even though the history seems like, this could be stroke. But the diagnosis has to be made. Got that?
Yeah.
Is there anyone in this room that does not know why this obstructive sleep apnea is diagnosed here? Anybody confused about any of this? Excellent. All right, let's go. Okay, yeah.
So if obstructive apnea is no airflow with movement in the ribcage is central?
Yeah, it is obstructive if there is movement. That means the person is trying to breathe, but air is not flowing because of obstruction. So you will see no airflow but movement.
So what about central?
If it was central, there will be no airflow and there will be no movement. Okay? Yeah. You got that? Moving on. All right, so this is what I get back from you, Wendy. I'm going to match this one. Adam's forward pen test. Okay. Abnormal sagittal pedicle axis. Good. Lambert sign. Come on. Lambert Eaton. Sternal angle deformity.
That'll be C. No, A.
Good. Tender costochondral swelling.
C.
Titis. Good. Stanley, which of the following is associated with antibodies to voltage-gated calcium channels on the pre-synaptic membrane?
Lambert-Eaton.
Good, Lambert-Eaton. All right. Ashton, which of the following is specific for airway obstruction in patients with sleep apnea? Specific for airway obstruction.
She said it. She said
Hey,
stereo.
okay, good. All right. Crystal. So you're gonna match this sideways curvature, outward curvature, vectors what?
No.
This kind of one.
Outward curvature is what?
Is that not kyphosis?
Kyphosis,
Yeah.
sternal protrusion,
Like this.
sunken sternum, double deformity. Good. All right, Tolu. 48-year-old male, hypertensive smoker. Chest pain for 2 weeks. Bless you. Constant retrosternal dull ache, aggravated by deep breathing, relieved with ibuprofen. Review of system is negative. No family history of heart disease. Works as a day laborer and has smoked a pack of cigarettes a day for 25 years. Physical examination, mild respiratory distress, elevated blood pressure. Physical examination is unremarkable except for a positive compression test. There is no costochondral swelling. This is the EKG. Question is, what is the most likely diagnosis in this patient? Costochondritis, okay. So you see, I mean, I threw the EKG there, threw uncontrolled blood pressure there, build up the risk. But the truth is, this is, everything here is costochondritis, okay? EKG even show LVH. LVH does not give you chest pain. It's angina that gives you chest pain. And the character of this pain is not consistent with angina. That is the reason I made a lot of emphasis on making sure you understand the characteristics of angina. It's a pressure-like pain. It is usually brought on by exertion. It is relieved by rest or nitroglycerin. Very important. Because in exams, they will give you simple stuff, but they will muddy the water with a lot of details you don't need. Sometimes details are distractions. You need to know when a detail is being given to you to distract you versus when it's being given to direct you as to what you should be thinking about. Okay, this is one example where the detail is distracting. All right, so, Maureen, in which of the following patients with orthopnea is orthopnea most likely due to a heart disease? Do you say D? C? 40-year-old male hypertensive with bladder leak, that's correct. Okay? So this is when it is due to a heart disease, the leg swelling. Because the leg swelling generally means that there is right heart failure. And the commonest cause of right heart failure is left heart failure. All right. Which of the following is associated with antibodies to cholinergic receptors on the postsynaptic membrane? Myasthenia gravis. Okay. Vinny, here is a 78-year-old female brought by daughter for new onset excessive daytime drowsiness. Past medical history, hypertension for 30 years, diabetes for 20 years. She's had 2 strokes. The last one was 5 years ago. Review of system is negative except for chronic constipation. On examination, she's alert and oriented, BMI of 28. Vital signs, normal. Physical examination, unremarkable. CT scan of the head, evidence of old ischemic infarct. This is your section of the sleep study recordings. Question is, what is the most likely diagnosis in this patient? Thank you. Central sleep apnea, because when there is no airflow, there is no movement. Okay, so it's a central airflow and central sleep apnea. You got it? Excellent. Kiera, which of the following statements about snoring in patients with sleep apnea is accurate? The loudness of snoring is indicative of the degree of airway obstruction. Snoring is specifically absent in patients with central sleep apnea. Is it absent?
No.
Thank you. Snoring is pathognomonic of obstructive sleep apnea. Thank you. Raleigh. So you're going to match these surgeries with the whatever. These surgeries with the causes of sleep apnea. Okay? So, palato-pharyngoplasty. What are you going to do? Where are you? Huh?
E.
E? Good. Higher suspension? Thank you. Higher suspension is from big tongue. It suspends the tongue, right? Septoplasty.
B.
Diaphragmatic pacing.
Is that obesity?
Central sleep apnea.
Diaphragmatic pacing. Don't ask me, I'm asking you. Central.
Central.
So nasal positive pressure ventilation.
Obesity.
Thank you.
Thank you. Yeah. You're welcome. Alright, save.
Snoring? Yeah, snoring is non-negative for central.